Cancer Management and Oncologic Emergencies. Our unit objectives are to apply the core knowledge of normal anatomy and physiology to the management of patients with cancer and oncologic emergencies, to differentiate among the purposes of surgical procedures in management of patients with cancer, describe the roles of surgery, radiation, and chemo in treating patients with cancer, describe the special nursing needs of patients undergoing treatment with chemo and radiation, and describe the etiology, signs and symptoms, and treatment for oncologic emergencies. So first we have to look at how cancer affects the patient before treatment begins. We have impaired immune and hematopoietic function. Our bone marrow has been invaded by the cancer frequently, leading to a decrease in the production of WBCs, RBCs, platelets, leading to some various hematopoietic problems. So they're already coming to us weakened. Altered GI structure and function. Tumors can obstruct or compress the GI tract, leading to a decreased ability to absorb nutrients, eliminate waste. It can increase your metabolic rate and increase the need for nutrients. How many times have you heard of that kind of red flag when patients go to a physician and say, "I don't understand it, doc. I've lost 20 pounds in the last month and I haven't altered my activity level or my diet." Everything goes ding, 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 ding when the doctor hears that. GI structure and function, the liver can be impacted, either by metastatic lesions or actually localized primary tumors in the liver. Changes in patients' taste, their ability to sense pain, their gait, other neurologic changes that can be impacted by the presence of cancer long before we start treating it with things like radiation and chemo and surgery, which can also alter our motor and sensory function. It can cause decreased respiratory function, the fact that we're not getting enough oxygen because of our decreased red blood cells, compression of the lungs, compression of the airway, obstruction, that sort of thing. So let's look at surgery as cancer treatment. We do it for a variety of reasons. We do it for diagnostic reasons. We do biopsies. We can use surgery to actually remove or debulk the tumor to ultimately, hopefully, promote healing or cure. We can do it for prophylactic reasons to prevent cancer from occurring, such as women who have high risks for breast cancer may elect to have a mastectomy. Women with high risks for ovarian cancer may choose to have an oophorectomy to prevent them from getting cancer. We can do surgery to determine the effectiveness of treatment, to serve as palliation, to reduce pain and other symptoms. We can use it for reconstructive purposes. We can do local excisions or even laparoscopic excisions, or we may have to do wide radical excisions depending on the size and the extent and the metastatic reach of the tumor. So when we look at surgery and side effects, think back to all the different things you learned about back in Nursing 110 in your peri-op course, but add to that the problems with hemorrhage and infection and loss of body parts or loss of function of body parts. You're talking about the psychosocial aspects as well, the fear, the anxiety as patients wait for the results of a biopsy, for example. So our nursing care is going to focus on physiological as well as psychosocial needs. Radiation as therapy for cancer. So what its goal is for that radiation to destroy cancer cells with minimal damage to normal cells. So the cells either die outright or they become unable to divide. The problem is killing off those cancer cells without damaging the surrounding healthy cells. So we can have external radiation, where it is external to the client, it is distant, and patients will have markings on their skin to target where the x-rays are supposed to go to hit that particular cancer. Or we can do what is called brachytherapy, which is internal, direct, continuous contact with the tumor. We can put in radioactive isotopes directly into the body in solid form, or we can put it in their body fluids, so intravenously, that sort of thing. And then we have brachytherapy is either sealed or unsealed. So sealed radiation is where the radioactive solid isotope is implanted within or very near the tumor, so like seeds or needles. The client emits radiation, so people around them can be exposed to that radiation, but their bowel and bladder function, their stool, their urine are not radioactive. We need to limit our visiting time. We need to shield ourselves from these patients. We need to limit no pregnant women or children under the age of 16 when patients are having sealed radiation therapy. Unsealed is either given orally or IV or instilled into a body cavity, like into a bladder in the case of bladder cancer. And in that case, their bodily waste, their stool and their urine will be radioactive because it's going through their bloodstream and now it is being metabolized and excreted through the GI tract or through the renal function. So in this particular case, because their bodily waste is radioactive, they need to flush several times after they use the bathroom so that the radiation is diluted. And then the concept of exposure versus dose. Exposure is the amount of radiation delivered, so the external or implanted radioactive material. The dose is the actual amount that the body absorbs. And that's impacted by the intensity, the strength of that exposure, the duration of this exposure, and the proximity of that radiation source. So when we talk about radiation side effects, possibility of radiation toxicity, we can have skin changes, rashes, burns, hair loss, altered taste sensation, fatigue because of increased energy demands, tissue fibrosis, and scarring because of inflammation. So our nursing management of patients who are getting radiation, if they're getting teletherapy, external radiation, we do not remove the markings. We administer prescribed skin care, so they are not to use any lotions or ointments on those rashes or burns unless they've been prescribed by the physician. They need to avoid direct exposure of the skin to the sun, so that's UV radiation of the sun can enhance those toxic effects of the radiation that they're getting for their cancer treatment. Xerostomia, Xerostomia, dry mouth. That can happen when patients getting radiation in the area of their neck or face. And bone that is exposed to radiation is more vulnerable to fracture. We call that pathologic fractures, when bones break without any significant trauma because they've been made more porous or more brittle by the treatment that the patient is getting. And then we have chemo, which is basically taking chemicals to treat cancer. And so they have a selectivity for killing cancer cells over normal cells, but any cells that are rapidly dividing in your body are going to respond to and probably be killed by your chemotherapy. So you learned back in Nursing 200 that cancers, tumors are when you have cells that are rapidly dividing much faster than what they're supposed to and how they are originally programmed to do so. So the chemo is selective to kill rapidly dividing cells. Unfortunately, there are other rapidly dividing cells in our body that can be susceptible to damage, such as our hair follicles, such as our testicles and our ovaries, our skin, the mucosal lining of our GI tract. So all of those are going to be impacted by chemo and end up being significant side effects for those patients. When you hear the terms neoadjuvant and adjuvant, neoadjuvant is when chemo is combined with surgery or radiation or both preoperatively to shrink tumors and make them more easily removed during surgery, or adjuvant where we give chemo post-op to kill off any remaining cancer cells. And the goals of chemo are for cure, obviously, that is our hope, or to increase our survival time, or to control the growth, or for palliation purposes to relieve pain or other side effects of the cancer, at which point the patients are having to make a choice between the side effects of the chemo versus what's being caused by the cancer, and which they would rather put up with, essentially. So treatment issues with chemo, we have the concept of cell kill and the cell cycle. So many of these chemotherapeutic agents are developed to stop the replication of cells at various points during that replication process. So they are timed for maximum kill and damage to cancer cells. We talked about body surface area when we talked about cardiac index. This is how we prescribe chemo based on the patient's body surface area, their height in centimeters, their weight in kilograms. So we have a square meters of body surface, and that is how we dose our patients. Chemo is usually IV, but it can be oral, intra-arterial, intracavity, intrathecal, where we put a catheter directly into, say, for instance, the brain to bypass the blood-brain barrier. And extravasation or infiltration is when the chemo infiltrates into the skin. And in the situation with that is that we need to stop the infusion. Don't slow it down. We need to stop it completely. Leave the IV catheter in. We are going to disconnect the IV catheter from the tubing, flush that catheter, not flush it, withdraw, aspirate, try to get as much of that chemo that has infiltrated the tissue out through that catheter, and then we can discontinue the IV catheter and put either a warm or cold compress, depending on the protocol for that particular chemo, which you will know if you are administering chemo, so we can remove as much of that irritant that can actually damage their subcutaneous tissues when the IV infiltrates. That's why we try in so many cases to put ports or PICC lines into patients who are getting chemo to avoid that potential problem of infiltration of those of a peripheral IV. When you are administering or preparing chemo, you need to take some precautions as well, because if you get that on your skin, it can be absorbed through your skin sometimes, or inhale it. So you will also be probably gowned and gloved and masked and everything else when you are administering chemo, which puts additional barriers between you and your patient at a very difficult time. General side effects of chemo, which we're all very aware of. So pretty much all chemotherapies will impact various parts of your body. Again, those rapidly dividing cells, like in your GI tract, patients will have nausea, vomiting, diarrhea. Hematopoietic, if patients have thrombocytopenia, which is reduced platelets, they're at risk for bleeding, they will be given medications to stimulate the production of platelets. Oprelvicin Numega is an example of something that we give for thrombocytopenia. Patients can become anemic because of a decreased number of red blood cells, so decreased cellular oxygenation, less energy, so we can give them Procrit, erythropoietin. So think Procrit in favor of hematocrit. So it builds up your red blood cells. And if we have a reduction in white blood cells, that is neutropenia, and that is a neutrophil count less than 550. and we have to put those patients on neutropenic precautions. So no raw vegetables or fruits, no flowers in the room, no visitors that are potentially contagious, like little kids who are germ factories. And the patient will need to wear a mask if they have to go anywhere outside of their room to protect them from infections. It can impact your reproductive organs, causing early menopause or sterility. It can impact your hair follicles, causing hair loss, alopecia, changes in your skin, anxiety, sleep disturbances. So those are kind of general types of side effects that we will get from most types of chemotherapy. Some patients will have them more severely than others. Others will cause more nausea, vomiting than others, that sort of thing. Targeted therapies, biological response modifiers, which target cancer cells and growth factors, and they stimulate your immune response. So interferon is an example. Now you can recall we talked about interferon back when we talked about some of our autoimmune neurological conditions. And patients can have very severe flu-like symptoms, chill, fever, peripheral neuropathies, rashes, depression. So these interferon biological response modifier types of targeted therapies can have some significant side effects. Gene therapy is where we are able to take, for example, a biopsy of a patient's tumor, determine the genetic makeup of that tumor, and then create a chemotherapeutic agent that specifically targets that genetic makeup of that tumor. So monoclonal antibodies are an example of a gene therapy. Some cancers are more susceptible and will grow more quickly in the presence of certain hormones. Some tumors will require specific hormones in order to grow and have their expanded, very rapid growth. So if we give them the opposite hormone, that can sometimes help to decrease or stop the growth of certain cancers. So for example, we may give male hormones to female clients who have breast cancer that are estrogen-based breast cancers. So we will give them testosterone. So some side effects of that could be hirsutism or facial hair, acne, mood swings, that sort of thing, if we're giving testosterone to females. Some prostate cancers will thrive in the presence of testosterone, so we will give estrogen-based hormones to males with prostate cancer. So some of the side effects of that could be what we call gynecomastia. They will develop breasts. And all hormones are going to increase the risk for DVTs. So any patients who are getting hormonally based chemotherapeutic agents, you have to be assessing them for DVTs and doing preventive measures for that. So let's move on to oncologic emergencies. There is a table in Chapter 6 of your Honan textbook, Table 6-6, that lists all of the oncologic emergencies and what caused them and what signs and symptoms are related to them. So we'll have a brief discussion of that, and one of your assignments for this semester is to do those clinical judgment maps for all of these oncologic emergencies. So let's start with superior vena cava syndrome. And this is where the SVC is compressed or obstructed by tumor growth. Remember, the superior vena cava is bringing fluid from the upper body to the right side of the heart. So it can occur a lot of times with lung cancers, lymphomas, some breast, esophageal, or colon cancers. It is a late stage manifestation, and so your signs and symptoms are related to the fact that blood flow is blocked. Venous return is blocked from the upper body. So they may start off with some edema of the face, especially around the eyes, something called Stokes sign, where because of the engorgement of their veins in their neck, their blouse or shirt collar becomes tight. Then it will progress to hand and arm edema, upper body erythema, dyspnea, nosebleeds, and late stages can cause hemorrhage, cyanosis, increased intracranial pressure, decreased cardiac output, and coma and death. So what we will do is to either surgically relieve and open up that superior vena cava with a stent, or do high-dose radiation or chemo to shrink that tumor and provide relief of that blockage. We can have spinal cord progression. So very similar to when we talked about spinal cord tumors. This happens when the tumor invades the spinal cord or the vertebrae crumble or collapse onto the cord. It can be metastatic. Sometimes we will have this with certain tumors that are highly metastatic to the spinal cord, to the spinal column, to the vertebrae. Patients will have back pain, numbness and tingling, loss of bowel and bladder control, muscle weakness. So our treatment is high-dose corticosteroids to reduce swelling and inflammation, high-dose radiation to decrease the tumor size, or surgery to remove the tumor or debulk it so that it is not compressing the spinal cord as severely. Pericardial effusion, cardiac tamponade. This is where, because of cancer treatment or the cancers themselves, patients will have an accumulation of fluid in the pericardial sac. So now you have muffled heart sounds because of the fluid surrounding the heart, shortness of breath, fatigue. Think of all the signs and symptoms of poor cardiac output, dull or diffuse chest pain, weakness. And so our treatment is going to be what's called a pericardiocentesis, where we drain the fluid from the pericardial sac and relieve that cardiac tamponade. DIC, we talked about at length when we talked about shock. This can happen in cancer patients because if they are very immunocompromised, they can develop sepsis, and then they can develop DIC. So you have your early and late stages. We need to be very careful with our patients who are immunocompromised, a strict aseptic technique, and we need to halt the process in the early stages when they are having massive clotting going on, because otherwise it will go into that process where they have now run out of clotting factors, and in the late stages they will be bleeding from everything, and then we have to treat that more specifically. SIADH, syndrome of inappropriate antidiarrheal hormone. So antidiuretic hormone. So there's too much. So we have massive fluid retention and edema. The lab changes, we have low sodium. All of our serum labs are going to be low because of hemodilution and fluid overload. All of our urine labs are going to be elevated because of decreased urinary output. So the urine is going to be much more concentrated. So with SIADH, our serum labs are going to be low, our urine labs are going to be high. And so we have these patients on strict INO and fluid restriction. We give them diuretics, and we gradually replace the sodium because their hyponatremia is one of the more significant causes of the signs and symptoms of SIADH. Hypercalcemia, too much calcium circulating in the blood, causing mental status changes, nausea, vomiting, constipation. So think with hypercalcemia, everything is sluggish, versus hypocalcemia that you learned about back in, I think, Nursing 110, where you have the twitchy muscles, everything's twitchy. So hypercalcemia, everything is sluggish. We have low potassium, low phosphorus, we have high calcium, we have nausea, vomiting, constipation, fatigue, muscle weakness, loss of reflexes, paralytic ileus. The cause of hypercalcemia is bone demineralization. Some cancers or chemotherapeutic agents can cause calcium to leach from the bones into the bloodstream, raising our blood calcium levels. Immobility, bed rest, can also cause bone demineralization. Our treatment is sometimes calcitonin, which helps to reabsorb the calcium into the bones, hydrating the patient, and in extreme cases, we may have to dialyze that patient. Tumor lysis syndrome. So we have too much tumor destroyed all at once by the chemo, which spills toxins into the bloodstream faster than the body can excrete them through the kidneys. We can anticipate it and we can prevent it. Our labs are going to show increased potassium, CK, myoglobin, and purines, and all of these can lead to acute renal failure because they clog up your renal tubules. To prevent this, if we know that this particular chemotherapeutic regime is at risk for TLS, we will hyperhydrate that patient the day before, the day of, and the day after chemo. We're talking up to 5,000 milliliters, so 5 bags of fluid each day to flush all of those toxins out before they concentrate so much that the kidneys can't filter them. We will give them allopurinol to reduce purines. We will do Kxalate, which can draw your potassium out and excrete it in your stools. And in extreme cases, dialysis. So let's talk about a little legal case study of someone who has had some issues. Plaintiffs are the surviving son and daughter of a terminal lung cancer patient whose arm was broken by a student nurse, not a Goodwin student nurse. This patient had a diagnosis of metastatic bone disease. The plaintiffs, the family, claimed the student was negligent by moving the patient without using a draw sheet. And they said, but for the fractured arm, the patient could have been cared for at home versus a skilled nursing facility during her final days, and they spent more than $26,000 for that nursing home. The defendant nurses claimed that there was no evidence that cancer had spread to the humerus and lifting by the arm was appropriate, and also claimed that the disease progression would have left the patient in the same state of disability. The verdict was $92,000 for the plaintiffs because she had a diagnosis of metastatic bone disease. They knew, the nurses should have known, that the patient was at risk for pathologic fractures. So not using the draw sheet, not being careful, was inappropriate substandard nursing care. So the plaintiffs won that case.